Welcome to AETCM, the emergency medicine channel. Sashanast. A 19-year-old female presented to the ER with alleged history of paracetamol overdose that she took on 18th of April around 9 am and presented to the ER on 6 pm. On our initial 10-second assessment, patient was conscious, oriented and obeying commands. Coming to airway was patent, no pooling of secretions. Coming to breathing, air entry bilaterally equal, respiratory rate of 18 per minute, a saturation of 97% in room air. Circulation BP of 120/80, heart rate of 74 beats per minute, all peripheral pulses equally palpable. Coming to disability, GCS of 15/15, bilateral pupil equally reacting to light and GRBS of 130 mg per deciliter. Coming to adjuncts of primary survey, VBG was taken showing a pH of 7.401, bicarb of 24.8, lactate of 1.8. ECG was taken showing normal sinus rhythm.
What is the importance of taking ABG and ECG in a case of overdose?
Ma'am, we are suspecting a paracetamol overdose. Then there can be hypoglycemia. We will look for lactate levels.
Hypoglycemia at what stage of paracetamol overdose it will come?
Stage 3.
Stage 3. That means pulmonary hepatic failure. That stage only it will be there. This patient presented after 15 hours. Okay. Only if the patient takes more than 900 grams, like that 900 mg, such doses only, there will be hyperlactatemia or metabolic acidosis, such changes initially. Okay. ECG?
ECG, if we are taking any co-injections along with paracetamol, we look at the, for example, TCA toxicity, that can be changed in the QT interval.
Okay.
Coming to sample history, a 19-year-old female, no previous comorbidities, presented to the ER with alleged history of deliberate self-harm with single injection of tab paracetamol 650 mg, around 8 tablets. Accumulative doses 5,200 mg on 18th of April at home around 9 am, following which she was immediately taken.
What lethal dose? Lethal dose means the liver injury can occur. What dose?
Sir, single injection of around more than 200 to 250 mg per kg or more than 12 gram at around 24 hours or 6 gram or 150 mg per kg over consecutive 2 days.
Only thing is, if there is already a pre-existing liver disease, then it will become half. Normally up to 8 grams it will not produce any problem. But in liver disease, even at 4 gram itself, they can have liver injuries.
So what is if suppose we are giving paracetamol to a patient, what is the maximum therapeutic dose of paracetamol that can be given?
Maximum therapeutic dose is 10 to 15 mg per kg.
That is the drug that can be given, the concentration which is, that is a dose, 10 to 15 mg per kg. Maximum therapeutic
4,000 milligram over 24 hour period.
We can give up to 75 mg per kg. As are told, in such some situations there will be a low threshold for the patient, like liver disease. What all are the other conditions where the patient will be having a low threshold for paracetamol?
Malnutrition, Gilbert syndrome, and concurrent therapy on ATT, phenobarbital.
Why these patients are having very low threshold?
Already the metabolism is taking place, drugs metabolism.
Their glutathione levels will be very low. So paracetamol, they won't be able to metabolize paracetamol.
She was taken to a nearby hospital within 1 hour and was administered stomach wash. She reached our hospital around 6 pm. There was associated...
message on the stomach wash in a poison case?
It depends on the time of duration, injection of poison intake. Within 1 hour, we will go with...
Ideal situation is within 1 hour. What are the situations you can extend the time?
Food intake. In case of paracetamol, food intake, opioids and anticholinergics will delay its absorption. So we can extend.
Not only paracetamol, any poisoning, normal duration within 1 hour we have to give stomach wash. What are the conditions you can extend your time period to 2 hours, like that?
In case of extended release
tablet, one. Second thing, massive amount. Okay, suppose the patient has taken larger amount, the clearance will take more time. So you can try Okay, but as per guidelines, it is less than 1 hour. If we are getting the patient in 1 hour, it is ideal. But in conditions like extended release tablet, nowadays we get a lot of extended release tablets. So there also you can try.
There was associated
What
nose.
happens in extended release tablet? You crush and take. What happened to the tablet?
Increases absorption.
Extended release tablets. If you crush
readily
and
absorption.
then it will become normally most of the extended release tablets are not for crushing and taking, except some few molecules like minipress XL and all. They have little different type of coating, but all other tablets once you crush, the extended release property will be removed. Okay, so extended release, all these things are only theoretical. But when a patient takes, normally they crush and put it in water and take. So that also will become a readily available tablet.
There was associated nausea present. No history of any vomiting, malaise, anorexia, abdominal pain, altered behavior. The last meal was taken around 7 a.m. No history of any similar episodes in the past. No history of any allergies. No history of any drug intake. Coming to general examination, no pallor, icterus, cyanosis, clubbing or generalized lymphadenopathy. Systemic examination, patient was conscious and oriented. CNS examination, GCS was 15/15, bilateral pupil equally reacting to light. GIT, abdomen was soft, non-tender and bowel sounds were present. Respiratory system, normal vesicular breath sounds, no added sounds. CVS examination, S1, S2 present and no murmurs. Our initial diagnosis was paracetamol overdose in stage 1.
Okay. What are the stages of paracetamol poisoning?
There are 4 stages of paracetamol poisoning. Stage 1 is within the 24 hours. In that time, the lefty will be normal. Symptoms like nausea, vomiting, anorexia will be present. Stage 2 is 24 to 74 hours. There can be slightly elevation in LFT. On clinical examination, we may get a right hypochondrial upper quadrant tenderness can be present.
All the stage 1 symptoms will be coming down, but there will be abdominal tenderness. Okay.
Coming to stage 3 will
What
be
all are the liver parameters that can get altered?
ALT, AST.
First INR will be elevated, then AST, ALT, bilirubin. Okay. Then
coming to stage 3, it will usually onset is 3 to 5 days. The patient can develop electrolyte abnormalities like glucose, phosphate, lactate levels can be elevated.
And coagulopathy.
And coagulopathy. And symptom-wise, patient can go into hepatic encephalopathy, coma, and finally can lead to death. Coming to stage 4, patient who survived stage 3 and recovered from stage 3 comes under stage 4.
Okay.
What is the basic difference between this SGOT, STPT, that is a liver enzyme, and PTINR? How do they differ when you are managing a case of liver injury? SGOT, STPT elevates you see in many conditions, including paracetamol, it elevates. PTINR elevates only in some conditions. What is the basic difference?
SGOT, STPT are produced by the hepatocytes, tells us about the viability of the
when it is elevated, that shows only injury. But the function is still preserved. Function is determined by
PTINR.
Albumin also determines, but the half-life of albumin is longer, nearly 3 weeks. So it will not drop very drastically, but INR every 6 hours we have to monitor. Not only in this condition, whether it is viral hepatitis, paracetamol poisoning, snake bite, everywhere INR has to be that can change in 6 hours. So ideally, you have to do it at every 6 hours. Okay, whereas SGOT, STPT, 1 or 2 days only it will elevate. Okay.
What is the pathophysiology of paracetamol poisoning?
Usually, paracetamol is metabolized mainly in the normal level, it is metabolized by conjugation into sulfate and glucuronides. A small amount of N-acetyl parabenzoquinone is formed, which is then conjugated by glutathione. If you take a toxic level of paracetamol, then more glutathione is needed for the conjugation of N-acetyl parabenzoquinone. So, if the glutathione depletes to less than 2/3, then more amount of N-acetyl parabenzoquinone will accumulate, and that will cause us hepatocellular injury by binding with cellular proteins.
It will cause central lobular necrosis. Okay.
In this patient, we send the basic investigations like
So how will the management differ based on the patient presentation? So some patients might present within first 1 hour, some will present within 1 to 4 hours, some will present after 4 hours, some might present after 24 hours. So how will the management differ?
if the patient presents within the 1 hour, we will go with gastric lavage and also charcoal of 1 gram per kg is also administered. If the patient presents within 24 hours of onset, then we will send mainly the serum paracetamol level will be taken.
Why?
Because the serum paracetamol level will reaches its peak concentration in 4 hours. So after 4 hours, we definitely have to go with serum paracetamol level.
If it is a single ingestion of paracetamol, so in such situation we will have to chart the Romac-Matthew nomogram. So that charting will happen between the 4 hours and 24 hours. So for that charting we need to do. So at the 4th hour we will have to take paracetamol levels, and if the patient presents with 4 to 24 hours we will have to chart, and based on that if we are getting the result of the toxicology result within 8 hours, then we can plan on starting N-acetyl cysteine if at all required or not. If the patient's level is, if we are not able to get the results within 8 hours, then we will start N-acetyl cysteine, and then based on the result we will plan on stopping or not. After 24 hours, is there any role of taking the toxic level?
Yes, ma'am. We will plot on.
After 24 hours, plotting might not be possible, but after 24 hours, if the level is more than 10 microgram per ml, then we will have to again give N-acetyl cysteine infusion. Okay. So this patient came at the 15th hour. Okay, then how did you proceed?
We initially sent the routine investigations, toxicology screening, serum paracetamol level, electrolytes, RFT, everything was sent. And we started the patient on N-acetyl cysteine because we were not aware about the dose. Actually, patient and the bystanders are saying dual history about dose consumption.
Okay.
And the packets were also not available in the home. So we did not wait for the serum paracetamol level. Since 4 hours later, we started the patient on N-acetyl cysteine. We go ahead with the 21-hour infusion protocol. Initially, we given 150 mg per kg dose in 5% dextrose 200 ml over 15 to 60 minutes, followed by 50 mg per kg in 500 ml 5% dextrose over 4 hours, followed by 100 mg per kg 5% dextrose 1000 ml over next 16 hours.
Okay. What is the oral regime that can be given?
Oral regime, we can, those who are not willing for IV drugs, and then in that patients we can give an oral regime, that is giving a
if at all the patient doesn't have any contraindications like any vomiting, anorexia, or if the patient's airway is patent and if the patient's sensorium is full, then we can plan on giving oral. What is the dose?
140 mg per kg per oral given as a start dose, and we will then followed by 70 mg per kg Q4H is given.
Up to 17 doses. Okay.
What are the other clinical utilities of N-acetyl cysteine? Clinically, where all you use in emergency room?
As an expectorant.
In dry cough or pneumonia, cystic fibrosis, all these things you can give it as a nebulizer. Other conditions?
In suspected hepatitis or
any hepatitis, now we can give N-acetyl cysteine. The action is it's a liver protective agent. Okay. So there also you can give. But normally we give in paracetamol poisoning. Nowadays we can also give this in other types of hepatitis, viral hepatitis.
What is SNAP regime?
SNAP regime stands for Subnetwork Access Protocol Regime. It is basically a 12-hour protocol regime. Usually we give a dose of 100 mg per kg over 2 hours, followed by 200 mg per kg over the next 10 hours.
Okay. Then what happened to this patient? We started N-acetyl cysteine.
We have sent the serum paracetamol level, and after the labs came, it was within normal limits. And we continue the infusion protocol. And by the end of protocol, we look at the ALT, INR, everything. It was within normal limits, so we stopped the NAC
Which is
protocol.
most important, ALT, AST or INR?
INR is most important.
At what level it is alarming?
1.5.
1.5 is alarming level for a normal person. Okay, more than 1.5, we have to be very careful. These patients' INR is normal.
Must know.
Other than N-acetylcysteine, when should we plan on any extracorporeal elimination and all in paracetamol overdose?
The patient is going into failure, means
Pulmonary hepatic failure features like altered mental status or metabolic acidosis, elevated lactate. In such condition,
Ingstone's criteria. According to that acetaminophen toxicity, either pH of less than 3 or lactate of more than
pH
3,
of
less than 7.3 or lactate of more than 3.
either pH of less than 7.3 or all of the
All the
below.
three other
Which all are they?
parameters. Creatinine of more than 3.4, INR of more than 6.5, and hepatic NK of grade 3 or 4.
Okay.
How creatinine is affected here?
Hepatorenal syndrome.
Renal pathway that is disrupted and selective hypoperfusion of kidney occurs. Okay, that's why creatinine increase. All liver failure ultimately kidney will have some amount of failure. Once you transplant the liver or remove the liver and put a new one, that part will be corrected. Okay. Acidosis due to
Lactic acidosis.
lactic acidosis, their ammonia increases and reduced circulation to splanchnic area. So many that produces lactic acidosis. INR,
And due to hepatic failure.
hepatic failure. What happened to the patient finally?
Finally, we discharged the patient. The serum paracetamol level was in normal limits. All the parameters were within normal limits.
What are the definitive indications for paracetamol in emergency room? Don't tell fever. Fever in
Therapeutic
this.
indication.
You tell fever in this, fever in this, fever in this, like that.
Analgesics. As an analgesic.
It is not a good analgesic. It can be analgesic in higher dosages. Like 1 gram is required. Where all you definitely give paracetamol. Some fever and all, you don't need to give paracetamol. There are some conditions you have to give paracetamol and control the temperature. What are the conditions? It's an emergency. Fever is not an emergency.
Febrile. Febrile seizures.
Febrile seizure. Okay. Then
Viral fever.
fever is not a febrile seizure. That is correct. You have to control the seizure. First you have to control the fever, then the seizure will get controlled. Other one is pregnancy with fever. Then cardiac failure or myocardial infarction with fever. Stroke with fever. Seizure with fever. These are the conditions you have to definitely control the fever. Suppose somebody coming with viral fever, there is no need of paracetamol. Just leave him like that, fever will subside. There are some patients, paracetamol allergy will come to emergency room. How do you manage? Paracetamol allergy is very common. How do you manage?
Mefenamic acid.
Some patients can have NSAID allergy also. Paracetamol with NSAID. Mefenamic acid is a good choice if paracetamol allergy is there. But somebody is having both allergy, what do you do? It's a very common scenario. Paracetamol allergy, and the same patient can have NSAID allergy also. And patient is having febrile seizure or something like that. What do you do?
IV fluids.
IV fluids will not control the fever. Steroid is one choice. Other one is hydroxychloroquine. That is a commonly given drug for all type of fever. That's why in malaria, if we start hydroxychloroquine or chloroquine, immediately patient fever subsides. That is not because malarial parasite is killed. Most of the malarial parasites are resistant to chloroquine. But even then, if you give a chloroquine tablet, fever will subside very fast because it's an anti-inflammatory drug. So you can use any anti-inflammatory, including NSAIDs. NSAIDs are also anti-inflammatory. But if the patient is having allergy to that also, then steroid is a good choice. Otherwise, you can give easily this hydroxychloroquine sulfate. 200 milligram if you give, fever will subside. So that we should know. How do you control the fever after blood transfusion?
If it is during blood transfusion, you have to stop the transfusion.
So then fever may persist.
We can give injection. I will.
You can give H2 blockers. There are H2 blockers. It is because of the pyrogens present in the blood, that transfused blood. Paracetamol can be definitely given, but you have to give some H2 blockers. Otherwise, fever will come back. Unknowingly, we give paracetamol with Avil, but the reason is pyrogens in that may precipitate fever after some time. Okay. Okay. Thank you.
Thank you.